30 minutes or so to talk about kind of what I think is a really important topic, which is, which is on stigma and the use of language when it comes to substance use disorders. And certainly I have no current or past financial arrangements, any disclosures to make regarding the contents of this activity. I think we're going to start just by appreciating that substance use disorders remain some of the most stigmatized illnesses. And then really go into how stigma can be a barrier to recovery, learn to recognize stigmatizing language, and sort of learn what our roles can be to start to combat stigma. And we'll try to do all that sort of in the next 25 minutes or so. So I start with this idea, right, that's kind of well known in medical literature, but I believe that it sort of forms a nice kind of an anchor around which we can talk about stigma, which is that addiction, substance use disorders are chronic diseases, not dissimilar to things like hypertension, diabetes, and asthma. And this is a concept that Dr. Maley introduced last week in her talk, right? Where we know, and this was I really recommend reading this paper if you guys have access to it and it's allowed. So this is way back in 2000, right? At the turn of the century, I guess. Tom McClellan from University of Pennsylvania looked at and compared our substance use disorders to other chronic diseases such as type 2 diabetes, hypertension, asthma, and looked at a few things. The first thing that the group looked at was the genetic impact, the heritability. In other words, what percentage of the contribution comes from your genetics versus what percentage of the contribution comes from the environment. And what they found was that genetic impact was similar. Turns out that with our substance use disorder, roughly about half of the impact comes from our genes and the other half comes from environment, which is actually about the same as type 2 diabetes, hypertension, and asthma. Tom McClellan and the group, they also found that the contributions to the environment and personal choice are comparable, and also medication adherence rates and relapse rates are similar between our substance use disorders as with our other chronic diseases. And therefore, long-term ongoing treatments, maintenance treatments are proven the most effective. So that was sort of a major finding. And it's actually a really well-written paper. It's easy to read and makes this point quite well. So despite this, I know there is some chat coming in, so I just wanna, okay, so it's just introductions here, I apologize. So despite this, treatments for our substance use disorders, and that's what SUD stands for, substance use disorders, remain disparate. And even now, 20 years after that paper came out, even in 2020, substance use disorders remain the only conditions in which patients are often expected to improve their conditions before being accepted into treatment, right? I still have patients who say, I was told that I gotta get sober first, detox myself before I can be accepted into a treatment program. Or non-compliance or lapse are grounds for dismissal. You know, I've done consults with clinics that have, for example, 3 strikes and you're out rules, where if they're treating someone and if they have urines that are positive for an illicit substance 3 times, they're discharged. Well, I often bring up the idea that would you do that again for someone with diabetes? If you're treating a patient with diabetes and their fasting blood glucose was elevated 3 times, we would never think about doing it. And yet we do it for our patients with substance use disorders. Withholding known life-saving treatment is considered and often done. And I know we have a psychologist on who's taking on what I think is a really important task of working with the legal system to implement medications for opioid use disorders, right? And if you think about kind of our prison system, our jail system, not only is this considered, this is often the norm, that these known life-saving treatments or medications for opioid use disorders are often not provided, which is completely medically inappropriate, and unethical. Known life-saving treatment is withheld or rationed. Active disease is considered to be a crime problem, right? We don't do this with our other illnesses. Patients are expected to discontinue known effective treatment. I have patients who are often told that, well, we can treat you for 2 months or 3 months, or some arbitrary amount, and then we have to detox you. We would never think about doing it if someone is, for example, taking metformin for their diabetes, right? Or hydrochlorothiazide for their hypertension. And often there is no or limited insurance coverage for effective treatment. So despite substance use disorders being similar to other chronic diseases in terms of genetic contribution, environmental contribution, treatment adherence, relapse rates, the way we actually provide treatment is disparate, is drastically different. In fact, we continue to treat our substance use disorders as acute illnesses, which they're not. And I think that sets us up for bad outcomes, right? And I would say that stigma plays a major role in this disparate treatment that exists, right? So let's talk about stigma a little bit, use that as a jumping off point. Addiction, substance use disorders appear to be among the top, if not the top most stigmatized conditions across different societies. And even compared to other mental illnesses, which are also highly stigmatized, people have even more stigmatizing and discriminatory views towards individuals with substance use disorders, right? This is an interesting study from 2014 done by Barry. And it's comparing people's attitudes, societal attitudes, and this is in the United States, towards individuals with mental illnesses, not substance use disorders, versus their attitude specifically for individuals with substance use disorders. I've listed the mental illness attitudes in blue and substance use disorder attitudes in red. So 62% of individuals who were surveyed in 2014 said they would be okay to work with someone with mental illness, right? But only 22% said that they would be okay to work with someone who had a substance use disorder. 25% believed that employers should be able to deny employment to those affected by a mental illness, versus a majority, 64% believed that employers should be able to deny employment to people affected by addiction, right? 21% opposed giving those with mental health the same health insurance benefits given to otherwise healthy individuals. And again, 43% actually said that they opposed giving individuals with SUDs the same health insurance benefits granted to otherwise healthy individuals. 90% were unwilling to have a person with SUD marry into their family, and 54% actually thought landlords should be able to deny housing to a person with substance use disorder, right? These are just numbers, these are statistics, but I would encourage you to reflect upon it when you have a time. What would our lives be like if these were the attitudes we were faced with day after day after day, where over half of people think that we should get less priority in housing, for over 40% think we should get less priority in healthcare, and the majority think that, you know, they wouldn't want to work with us or have us be employed with them, right? Think about what it would be like for us if we were in the same scenario, living this life day after day. And healthcare providers are not immune from this stigma. And often healthcare providers perceive things like violence, manipulation, and poor motivation when they're working with individuals with substance use disorders. And often lack of training, education, and support play a role in it. It's interesting, there was a study done back in the 90s that followed medical residents. And what the study found was that as the residents went through their training, their views towards individuals with substance use disorders became increasingly stigmatized. So in 2017, Avery and team tried to sort of see if that still held true 2 decades later. They looked at psychiatry residents. I know we've got Dr. Ferre on, so just want you to reflect on it. And even in 2017, what they found was that psychiatry resident attitudes towards patients with substance use disorders worsened. They became more stigmatizing through the course of their training. So we're clearly not doing something right. And you know, I think there are many factors. One is that there is this whole hidden curriculum. You know, I remember when I was a trainee, and, you know, there would be working in the emergency department or inpatient units, people who are coming in because of substance use disorders would often be referred to as frequent flyers or addicts or people who are taking up resources. And I think that has an impact, I believe. Also, I think in training, we often don't see people who are doing well, people with substance use disorders who are doing well. We never get that full picture. We often only see people who are not doing well, right? Who are acutely destabilized. So I think we kind of miss this whole other side of substance use disorder. So I think there are things that we can certainly address, but we're far from it still in 2020. Let's see. So moving forward, stigma and language. And I've used this example of dirty urine or positive urine because I think I hear this a lot, people saying so-and-so has a dirty urine. Versus I think what we encourage people to say is just using objective terms like the urine was positive for a particular substance or the urine was unexpected to launch into a discussion with the patient, right? So two commonly used terms, right? Substance abuser, which we hear a lot, kind of implies kind of willful misconduct versus having a substance use disorder, using that person first language where it may imply a medical malfunction, medical illness. But does it really matter, or is it just semantics? That's the question, right? Are we just being too politically correct? Is it just semantics to care about the language we use? So I turned to this study. This is sort of a classic study that was done where they took two groups of people, randomized, right? They took participants randomized into two groups, and both groups read the same vignette, same story about a person. Everything was same, except the first group read about someone who had a substance use disorder. And the second group read about someone who was a substance abuser. So that's the only thing where there was change was that language, substance abuser versus a person with a substance use disorder. And then they asked them a number of questions to look at their attitudes about this person. And this is the amazing thing, I think. So all the way to the left is treatment, right? Like, should the person be receiving treatment? Is treatment indicated? And when someone read about a substance abuser, about 40% thought the person should receive treatment and about 60% did not think the person should receive treatment. But when the group read about a person with a substance use disorder, 70% thought the person should receive treatment and only 30% thought they should not. Similarly, the second one is punishment. When someone read about a substance abuser, right, almost 70% thought the person should be punished. But when they read about an individual with a substance use disorder, only about 25% thought the person needed punishment. And similarly, you can see social threat, where, is the person a threat to society, significantly higher if the person had read about a substance abuser, right? Attribution blame, like, is it their fault or not, right? So I think you can see that language matters. That's the point I'm really trying to make here, right? That the language you use matters. So being mindful of it is important. Next, stigma, we know, worsens outcomes. So I just want to kind of highlight that piece a little bit. We know that when an individual is faced with stigma on an ongoing basis, on a daily basis, that stigma is internalized. The person turns that stigma inwards, right? And that leads to a number of things such as shame, guilt, low self-esteem, low self-efficacy. What's been termed the why try effect, which is learned helplessness. That why even bother? People are gonna keep seeing me this way anyway, right? Demoralization as well as feelings of inadequacy can all happen with this self-stigma, which is when the stigma is turned inwards, right? In other words, hello, I am what you label me, right? What I'm labeled can really become internalized and become the way I act, the way I behave, the way I relate to the world or even to myself. This is a study that looked at perceived stigma amongst patients and found, right, again, that when this is individuals with substance use disorder, that a majority believed that people treated them unfairly because they knew about their substance use. Almost half felt feared because of their substance use, and almost half felt abandoned even by their family due to their substance use. And then there's this big gap. Self-stigma has been related when it comes to treatment, with individuals with substance use disorders being less likely to seek help or treatment, right? Report high discrimination, being feared, being abandoned, as I mentioned, and also more likely to drop out of treatment due to stigma, which is in many ways the worst thing that can happen. Because when people drop out of treatment, their outcomes worsen. And that's been shown in every major study done in the 21st century. On the other hand, healthcare professionals often hold patients with substance use disorders in poor regard, view them as being poorly motivated, violent, manipulative, and may avoid these patients or shorten visits, leading to suboptimal care. So you can see how this stigma can start to affect treatment outcomes, right? Let's see here, go forward. This is kind of summarizing the outcomes a little bit. So recovery is a term we use a lot. Again, something that Dr. Maley introduced in our topic last week. And people have often talked about, well, what is recovery? What does recovery mean? What are the components of it? And according to SAMHSA, according to ASAM, according to kind of the, even the APA, American Psychiatric Association, there are several components to recovery. One is health, both physical health as well as emotional health. One is home, right? Having a stable place to live, a safe place to live. One is a sense of purpose, right? What is my role within my community? What's, what do I strive towards? What are my values? Community is another one. Having people that you can trust, having people you can talk to, having those stable, supportive group of people that form your community. And ultimately, hope for the future is the cornerstone of recovery. Note that nowhere in there does it say complete abstinence from all substances, right? Complete abstinence is not a key component of recovery, right? Someone could be not using any substances, but they could still not be in recovery if they're still struggling with a lot of these other things, for example, and vice versa. So just wanted to point that out. So if we think about those recovery components, well, turns out that stigma tends to worsen outcomes in all of those recovery components. We know that people who are faced with stigma are less likely to seek and stay in treatment. Therefore, likely they experience, and this has been shown, that people who experience a high degree of stigma experience worse mental and physical health. Well, so there, it clearly goes against or prevents a barrier to the health component of recovery. They have decreased employment, thereby going into that purpose piece, right? Having a purpose. They have unstable housing, which clearly is a barrier to the home component of recovery. They have breakdown of social support system, which is that community piece. And ultimately, we see that with stigma, you got worsened substance use disorder outcomes. And this is why I think stigma is so important to talk about early on in our cycle, because it's so prevalent, as we pointed out, and it clearly worsens outcomes for our patients, for our community members. So I leave here with what can I do? Just a couple of slides on what can our role be. I think a lot of it, sounds simple, but I think it's very important. I think it's important to treat people affected by addiction with substance use disorders with respect. Learn about the science of mental health condition just the way you guys are. And I think correct others who have misconceptions about substance use disorders and mental illnesses in general. Support resources. I think that's a huge piece because policy plays a big role. As I was pointing out, we continue to have these disparate policies, right? And I think supporting appropriate resources, supporting appropriate policy are very important. Educate. Appreciate that most people with substance use disorders do make recovery. This is not hopeless. Most people do well. Most people make recovery with treatment. It may take a long time, may take months or even years. But most people are able to return to productive lives. Be a personal witness, put a face and voice on recovery, which is tremendously courageous thing to do. Change our language and terminology. And we can start moving towards this idea that I'm not my addiction, that I am more than my addiction. Be an advocate most of all for your patients, within your clinics. Help create that accepting patient-centered environment. Work with your tribal, state, national leaderships to enact policies that will benefit our communities, including funding for treatment, drug take-back programs, education efforts, youth engagement. All of these things are super important. These are just some stigmatizing language versus preferred language examples. I point this out that here, and we continue to use the word MAT, or medication-assisted treatment, right? Which kind of replaced opioid replacement, which was an older term. But now some of the newer studies are finding that even medication-assisted treatment can lead to sort of negative implicit bias, where people can get this pop-up negative reaction when they hear medication-assisted treatment. So increasingly, although we continue to use medication-assisted treatment, the preferred term is becoming medications for opioid use disorders or pharmacotherapy for opioid use disorders. So I point that out, just something to think about. There is also the Anti-Stigma Toolkit by ATTC Network, which has some important things and things to consider. And then some references that I've used. If anyone's interested in a particular reference and you're not able to access this, please feel free to let me know. and it's 12:28.